Hello, everyone. My name is Rachel, and I'm the patient navigator for the University of Maryland PKD Clinic. Welcome to the 2025 PKD Education Forum, collaboratively put on by the PKD clinics of University of Maryland and Mayo Clinic, Rochester. We're so grateful that you gave us one of your precious weekend mornings to come and learn about PKD and community build. We have a good program coming up. As you can see, there are 3 main topics divided into 5 presentations. Each presenter will have their own Q&A following their presentation. For questions and answers, we will be moderating the chat and looking for live audience questions, and we will be alternating those if they both are coming in. Without further ado, I'd like to introduce our moderator, Dr. Terry Watnick. She will be helping run this Education Forum today. Dr. Terry Watnick is a professor of medicine in the Division of Nephrology at University of Maryland. She is the University of Maryland PKD Clinic Director and specializes in cystic kidney disease. As a nephrologist and researcher, she keeps a full clinic schedule and has been involved in many research studies with AD-PKD. Hi, Terry.
Thank you, Rachel, for that introduction. And I just want to thank everyone, again, as Rachel said, for sharing your morning with us. Those of you online, those of you in person, we appreciate it. So our first topic today is going to be general understanding of PKD. We're going to go over clinical features and genetics. Our first speaker today is going to be Valeriu Cebotaru. Dr. Cebotaru is a colleague of mine here at the University of Maryland. He's a nephrologist and has been in the PKD field for more than 15 years. He's studying PKD in the research lab, and he also sees patients in our clinic. Our second speaker is Dr. Neera Dahl, another colleague of mine. She's a professor of medicine and director of the Mayo PKD Center of Excellence. She completed her MD and PhD at Tufts School of Medicine and then did her internal medicine residency and nephrology fellowship at the Beth Israel Medical Center in Boston. And with that, I'm going to turn it over to our speakers.
I'd like to thank you, Terry and Rachel, for inviting me to give this presentation. I will talk about the clinical signs of AD-PKD. So, polycystic kidney disease, as name implies, present with multiple renal cysts in both kidneys. And if you look at this image in the right upper panel, there are multiple renal cysts in both right and left kidney. And there's also a transverse imaging that shows right kidney and left kidney. And there are multiple renal cysts in both right and left kidney. It's not uncommon with aging to develop one or several renal cysts, but that it's not AD-PKD. If you look at the right lower panel, there is an imaging from a patient who has a single cyst in the right kidney. It can be one or several cysts, and these are just simple cysts. This is not AD-PKD. So AD-PKD is the most common type of inherited kidney disease, and it occurs in 1 out of every 4 to 1,000 people. As I mentioned, it presents with multiple renal cysts in both kidneys. AD-PKD leads to end-stage kidney disease in about 15% of the patients, and end-stage kidney disease means renal function is very low, and dialysis it's necessary to replace kidney function. AD-PKD affects multiple organs. Besides renal cysts, it can present with liver cysts. If you look at this image in the right upper panel, it's shown from a patient with multiple liver cysts that are enlarged. This is an extreme case. Most patients have smaller liver cysts. Next image is shown from a patient who has enlarged abdomen due to enlarged kidneys and enlarged liver from multiple renal and liver cysts. AD-PKD can also present with intracranial aneurysm, and this image in the right upper panel shows intracranial aneurysm. AD-PKD can also present with heart valve abnormalities, abdominal wall hernia and inguinal hernias. It can present with colonic diverticula, shown in the right lower panel. These are circular dilatations that are arising from a large colon. It can also present with seminal vesicle cysts and male infertility. ADPKD is a genetic disease, and it's caused mostly by mutation in PKD1 or PKD2 gene. About 78% of the patients have a mutation in PKD1, and these patients have a more severe disease, and they will reach end-stage kidney disease in mid-50s. About 15% of the patients have a mutation in PKD2 gene, and these patients have a less severe disease, and they will reach end-stage kidney disease in late 70s. We use GFR, which stands for glomerular filtration rate, to measure renal function, which is expressed in ml per minute adjusted to body surface area. For simplicity, I like to use percentage as a measure of GFR. So normal GFR is between 100 and 125. And when GFR is less than 10, then dialysis is required. And this is called end-stage kidney disease, so ESKD. So where are cysts originating from? So if you look at the right upper panel, it shows a renal tubule, and there is a filter, or we call it glomerulus, but you can think as a filter, but blood is filtered, and then urine starts to form or accumulate along this tubule, and then will end up in a bladder. There are approximately 1 million filters in connected to a tubule, to these tubules in each kidneys. And if you look in the right upper panel, it shows that renal cyst starts to develop from all segments, from all segments of a renal tubule. So renal cysts are slowly enlarging over time due to fluid accumulation. And if you look at this image in the left lower side, you can see relationship between the cyst growth, GFR shown this in a red line, and age. So patients start to develop cysts early in age, in late teens. They may have small renal cysts, and over time this cyst will grow, and at some point renal cysts will displace most of the renal tissue. So, and when cysts are growing, of course, kidneys are getting bigger. So if GFR declines very slow over several decades, but at some point there is a rapid decline in GFR when renal cysts displace most of the renal tissue. And this is image is important because if you start treatment of ADPKD at this stage, then you can slow down decline in GFR. But if you start treatment of ADPKD very late, when GFR it's declining, then at much faster pace, then probably it's too late to slow cyst growth and decline in renal function. So not all cysts are equal, and for this reason, patients with ADPKD have been divided in 5 classes based on how fast cysts are growing. But basically, there are 2 categories. If you, this blue line shows that patients are divided in slowly progressive ADPKD and rapidly progressive ADPKD. And we use total kidney volume to determine if patient has a slowly progressive, rapidly progressive ADPKD. So we use MRI or a CT to measure kidney volume, and then to determine if renal cysts are growing slow or fast. So if total kidney volume is growing less than 3% per year, then those patients have a slowly progressive ADPKD. And if total kidney volume is growing faster than 3% per year, then those patients have a rapidly progressive ADPKD. And this is important because treatment it's not the same for rapidly progressive or slowly progressive ADPKD. So if you look at this image in the right lower panel, this shows kidneys from a patient with slowly progressive ADPKD. You can see these white dots. These are renal cysts, but you still can see a black area in the cyst. So this is normal renal tissue. So this is a slowly progressive ADPKD. But when you look at the right middle and right upper panel, so these are from patients with rapidly progressive ADPKD. And as you can see, there are multiple renal cysts that displace normal renal tissue, and you cannot see normal tissue on these two images. So there is also a correlation between decline in GFR and rapidly or slowly progressive, or slowly progressive ADPKD. So even with aging, GFR will decline, and this is shown in this black line. In slowly progressive ADPKD, GFR will decline faster than in a normal patient, but not fast enough to reach end-stage kidney disease. So in this graph, patients were followed for 20 years, and this, if you look at this dark green and light green lines, so when they start to monitor this patient when GFR was around 75, over 20 years GFR was 60 in this case, or you look at dark green line, or 30 light green line. So these patients have slowly progressive ADPKD, and they require a less aggressive treatment. Now, if you look at this yellow, orange, or red lines, it shows that GFR decreased from about 75 to 0 in 12 to 20 years. So these patients require a more aggressive treatment to slow down cyst growth and to slow down decline of GFR. So ADPKD presents with abdominal pain, flank or lower back pain, high blood pressure, and blood in the urine. Abdominal pain, it's caused, abdominal flank and back pain is caused by a large kidney or large cyst, cyst rupture or cyst bleeding, which can present also with blood in the urine. Infected cyst can present with back pain and also will present with fever. Kidney stones will present with back pain also. So how should we treat someone with ADPKD? In this case, I'm talking about symptomatic treatment, not about treatment of cyst growth. So if someone has abdominal pain or flank and back pain, then we recommend acetaminophen, also known as Tylenol. You should not take NSAIDs, which includes ibuprofen, Motrin, Advil, Aleve, naproxen, and indomethacin. And if you're in doubt, then you should call your nephrologist to ask which pain medicine you can take. If someone has bleeding in the urine, then we recommend to avoid strenuous exercise. A patient needs hydration, IV or oral hydration. If someone has an infected cyst, then we would prescribe antibiotics. If someone has kidney stone, then the best treatment is prevention, and in this case, it's recommended to increase water intake. Now, if renal stone it blocks a tubule, then in this case, a patient may need to see a neurologist for stone removal. I mentioned at the beginning of my talk about extrarenal manifestation of ADPKD. So about 80% of the patients have liver cysts, about pancreatic cysts are present in about 10% of the patients. About 10% of the patients develop intracranial aneurysms. It can also present, patient can also present with heart valve abnormalities, diverticular disease, and abdominal wall and inguinal hernias. When it comes to liver cysts, both females and males develop liver cysts, but females develop liver cysts at earlier age because yes, and cysts also larger in females, particularly in those who had multiple pregnancies, because most likely due to sensitivity to female steroid hormones. Most liver cysts are asymptomatic, but in rare cases, it can present with pain because the cyst can be infected or large cysts can cause pain. In rare cases, liver cyst drainage may be required. So some patient presents with intracranial aneurysm, and you should think of aneurysm as a cyst that develop out of a brain artery, similar to a cyst that develop out of a renal tubule. So intracranial aneurysms can rupture, and this is a medical emergency. It would present with a severe headache, often described as a worst headache of my life. And if someone has a ADPKD, has a severe headache, then they should call 911 immediately. Family history of a rupture presents a risk factor for rupture. And it is recommended to screen for brain aneurysms with MRI brain in those who have a family history of intracranial aneurysm. If someone has a family history of ruptured aneurysm, if someone has frequent headaches or migraines, or if someone has a high-risk profession such as airplane pilots. If none of these risk factors applies, but if a patient with ADPKD have anxiety and wants to know if they have intracranial aneurysm, then MRI brain can be ordered as well. If someone has a family history of aneurysm and a negative MRI brain, then it's recommended to repeat an MRI in about 5 to 10 years. If a brain aneurysm is detected by MRI brain, then patient is referred to neurosurgery for further evaluation. All women of reproductive age should receive counseling. There is potential aggravation of liver cysts with exposure to oral contraceptives. Women with normal blood pressure and kidney function have a favorable course during pregnancy. Multiple pregnancies, usually more than 3, have been reported to have a greater risk for decline in renal function and ADPKD. In general, it's recommended to avoid hard contact sports in patients with ADPKD, but there is no hard data to suggest that contact sports represent an unacceptable risk for the majority of ADPKD patients. Thank you for your attention.
All right, we have our first question. Are there any dietary interventions shown to help with the progression, like eating low carbs or keto?
Current recommendation is by experts in PKD is that to decrease calorie intake, because that slows ADPKD progression. In terms of keto, there has been a small study out of Germany, and they show that with the keto diet, there is increased risk of formation of uric acid stones, and also that can cause increased cholesterol. So keto diet is not recommended at this time, from what I know.
Any questions here?
Do you recommend physical therapy for the back pain?
Yes. Question was whether we would recommend physical therapy for back pain. Yes, absolutely. Yes. Yeah, I would recommend physical therapy for back pain. Yeah.
Oh, sorry.
Other than actual replacement of the kidney when the condition becomes severe, are there any other surgical interventions that will assist, such as puncturing of the cysts early on, cauterizing of the cyst areas, something like that, in order to relieve pressure on the surrounding kidney tissue?
There is no data to suggest that if you puncture a cyst that will have an effect on renal function. But if someone has severe pain, and then yeah, that can be done. Yeah, that might help with pain. Yeah.
Okay, so we have another question. Can you elaborate on the gastro issue, please?
I'm not sure I understand.
Oh, maybe diverticulosis and also GERD, maybe?
Yeah. Yes. Patient can have one of the extrarenal manifestation is diverticulosis. And this diverticulosis can also be seen in patients who don't have ADPKD. It's just slightly more common in patients with ADPKD. And the treatment it's probably low, just a high fiber diet. And if someone has a recurrent diverticulosis, then would refer patient to gastroenterology. If someone has large liver, then this can cause acid reflux. Again, the recommendation would be the same as for anyone with acid reflux, just to eat at least 2 hours before going to bed, and decrease, fat food, food that high in fat, and if it doesn't help, then there is treatment for acid reflux, yeah, H2 blockers and.
Okay. Could a mini stroke or a TIA hide as a brain aneurysm?
And no, I don't think so. No, TIA and brain aneurysm are different. TIA, it's just a small, it's a blockage in a blood vessel. Brain aneurysm is a dilatation, and when it ruptures, there is a bleeding in the brain. So those are two different things. Yeah.
All right. So you mentioned that GFR declines to around 10, a patient would need dialysis, but shouldn't patients plan for transplant first? When GFR is 20 to 30, we have so many years to plan for this. It makes sense we should focus on transplant and planning early. And I will say we do have a specific talk on transplant that will be coming up, but if you want to elaborate.
Yeah, so general recommendation is to refer to transplant evaluation when GFR is less than 20. But as Rachel mentioned, we'll have a detailed talk later today. Yeah.
All right. Question. The keto diet helped me reduce my kidney size, and I'm a professional dietitian with ADPKD. I think that's more of a comment.
Yeah.
And I think everyone is maybe specific. I think they're looking at the research on keto and PKD instead of just one patient case. Let's see. There is a focus on oxalates in parts of the PKD community. What is your take on this?
Well, okay, so I'll just go ahead. I mean, I think the issue with oxalates is that it predisposes to kidney stones. So you just want to avoid that. And that's true in PKD, but probably for people who don't have PKD as well. And that's one of the downsides of the keto diet, is this high oxalate issue. So, yeah. So should we move on? Let's move on to, are we, here for a few more minutes? Okay, go ahead then. Okay. Your slide indicated a 50% risk of end-stage kidney disease in ADPKD. This is surprising. I would have expected this to be higher. Well, I think overall it's in the about 62%, but it really depends on the genetics. So if you have PKD1, it probably is quite a bit higher. and depending on the mutation. But for those with PKD2, there are people who can really make it to like 90. I have had some patients who are 90 and do not have end-stage kidney disease and have PKD2. Oh, go ahead, Beth.
So as I mentioned, every cyst is different. If you have ADPKD, what I would recommend to see a nephrologist. So when I see a patient, they get an MRI and we measure kidneys, and then we plug this into a formula, and we get exactly your risk score. So we'll tell you. Of course, it's an estimate, but estimate, you will develop end-stage kidney disease in 10 years, 20 years, and this will determine what kind of treatment you need.
Okay, we have a few more minutes for questions. I just want to ask, does anyone in person want to ask a question before I continue with the virtual questions? Okay. All right. Is increased water intake suggested? For instance, someone who is 160 pounds, usually half body weight, is often suggested 80 ounces. But would someone with PKD want to have more?
So a general recommendation is 3 liters of water a day, 2.5 to 3 liters, so that about 3 liters would be 96 ounces, but actually goal is to decrease osmolality less than 280. So if you drink 80 ounces and your osmolality is less than 280, then probably it's enough. But
All right. I have frequently heard that cyst removal is too high of risk. Has that changed? Is there new technology?
usually we don't recommend to cyst removal for most of the patients unless, as I mentioned, if someone has a large cyst and it's just causing a lot of pain. In some patients who are undergoing renal transplant, then cysts, kidneys are removed if they're very large. Yeah. But if risk is the same, not sure.
I would just say it's really individualized, right? I mean, people have all kinds of other issues that has to be factored in, so I think you can't probably make an overall. I mean, definitely there are more laparoscopic techniques and robotic assisted surgery, hand assisted surgery, but I think it's hard to assign an overall risk.
There is a question, are there different symptoms for PKD1 versus PKD2 other than the rate of kidney decline? No, symptoms are the same for PKD1 and PKD2 patients. Next question. Do GFR levels vary naturally? How often should they be tested, and when is a decline meaningful when measuring onset of disease? So I would recommend to check GFR at least once a year, and if it's less than 60, then probably twice a year. Yeah, and then if it's lower, then even more frequent.
We can do 2 more questions.
2 more questions, okay. There is a dietary supplement that mimics ketosis in body via a beta hydroxybutyrate. Since keto is hard to maintain, might and can be high in meat. Might this be something to do instead? Not sure.
I mean, I don't know if it's harmful, but I would just say it's not. There haven't really been extensive studies
Yes,
one way or the other.
So usually I don't recommend anything that's not approved by FDA or haven't been tested. So it may work, but since it hasn't been approved by FDA or tested in a large population, so I cannot recommend it. Last question, what would be your recommendation for brain aneurysm screening in pediatric patients who cannot speak yet under age of 2? Probably it's too early, and I don't think they need to be screened at the age of 2.
Yeah, so aneurysms in kids under 18 is almost reported. It's very, very, very rare. So I think even with a family history, that screening earliest is about 18, unless there's some other reason. I mean, there's always exceptions to every rule, but in general, 18 and older.
All right, thank you, Dr. Cebotaru.
Going to turn it over to Neera Dahl. Hi, Neera.
Hi there. Okay, great. So it's such a pleasure to be here today and to talk to you guys, and I really enjoyed all of the questions that were generated from the first talk. Some of you may know that an organization called KDIGO, which is an international organization that stands for kidney disease, set global outcomes, establishing global outcomes. I'm forgetting the I part, but it's a big organization that recently just looked at kind of the whole database for what we know about clinical management of ADPKD, and they published KDIGO guidelines for ADPKD. And some of the things that are new in there are how to consider genetics and genetic testing. And so that's what I'm going to be speaking about for the next few minutes. And a lot of what you'll see comes from this KDIGO data set. And so you may have already seen some of this. For those of you who happen to catch another webinar that Dr. Watnick and I did earlier this week, we reviewed some of this information already. But this is just a first approach for how we think about diagnosing ADPKD. So many people may have cysts either in the kidneys or in the liver, seen by either ultrasound or CT or MRI. And usually we don't think that's PKD unless there are cysts in both kidneys. The kidneys are enlarged and they're symmetrically enlarged. So we're looking for all of those things before we think that it may be ADPKD. But if someone does have that, multiple kidney cysts, bilaterally enlarged kidneys, no other features that make us think of another disease, that imaging is enough to say that's ADPKD. And, you know, Rachel mentioned that sometimes people have a few cysts and they're wondering, do they have ADPKD? So that's really what we're looking for. If we're not certain after we look at the imaging, then we think about doing more testing. That might be genetic testing, or for a young individual that might be doing a different kind of imaging. So if we started with an ultrasound, it might mean getting an MRI. And then if with that we can make a firm diagnosis, we'll diagnose ADPKD. If we still can't make a firm diagnosis, we may follow up in the future in a few years to look for further imaging and see if now the diagnosis becomes clear. So the key point here in diagnosing ADPKD, if the kidneys look different from each other, so one kidney looks normal and one kidney looks cystic, we think that the risk of progression is low because that one normal kidney will still be able to provide the important functions of the kidney. Genetic testing may be helpful if there's a uncertainty in the diagnosis. And everybody, particularly as we age, may develop a few kidney cysts. And so distinguishing that from ADPKD is really important. And ADPKD, the incidence is about 1 in 1,000. And of all patients with ADPKD, about 10 to 25% do not have a family history. Hypertension or high blood pressure is common. That 50% of kidney failure you heard about in the first talk, and the Mayo imaging classification you also heard about. So Mayo 1C, 1D, and 1E are at the highest risk of progression. And patients who have that atypical imaging where the kidneys don't look the same are at lower risk of progression. And this is an autosomal dominant disease. So what this means is for PKD1, PKD2, for the genes that cause ADPKD, all of us have 2 copies, one inherited from each parent. And in this disease, you just need one disease causing variant to have the disease. So this is an affected father, so he has a normal allele, a normal version of the PKD gene, but then he also has a disease-causing version. And for him, each of his children has a 1 out of 2 risk of getting this affected or disease-causing gene. And so here you can see what a typical family would look like, where if the parent is affected, on average, 2 out of 4 children, or 50% of the children, will be affected. And we know that PKD1, it's a bigger, more complicated gene. It has a much bigger impact in this disease. It causes 78% of the disease. And PKD2, which is the milder one, causes about 15% of the disease. And here you can just see graphically. So what I'm showing you are 2 different MRI images of kidneys. And this is the kidney for someone with a PKD1 variant, with a very aggressive PKD1 variant, where the kidneys are all basically replaced with cysts. And here you can see someone with a PKD2 variant in panel B. And here the kidneys are much more normal looking. So this dark tissue is normal kidney tissue. And then you can see this person has a few large cysts. The sort of bright white balls are the cysts, but it doesn't look anything like this person who has a PKD1 variant. And then when we look at the population as a whole, trying to sort out who has what gene variant causing the PKD, what we find is that there's a class of variant within the PKD1 variant called a truncating PKD1 variant. And what this means is, if you can imagine, the body is very interested in having all functional proteins. So if only part of a protein is made, or a truncated protein is made, that gets recycled and isn't used. And so people with truncating PKD1 variants tend to have the most aggressive disease. That means they have no polycystin expressed from that variant allele. People, the next most severe are PKD1 non-truncating, where a full-length protein is expressed, but there's one change. So one amino acid, one building block of that protein is slightly different. And those people have disease, but it's not as severe as the people who have no protein at all. And then the next most severe are the PKD2 variants. And then what's really new from the KDIGO guidelines is that there's a whole bunch of other minor genes that look like PKD1 and PKD2. And so we'll look at those in just a minute. So now, because we're understanding that there's an importance of knowing what the gene is that might be causing the PKD, what KDIGO recommended was to, if you know the gene, to put that gene name in the diagnosis. So I may say, this is patient X and he has 80 PKD-PKD1, or this is patient Y and he has 80 PKD-PKD2. And so that listing the 80 PKD plus the gene name helps us think about how that patient is likely to progress, whether they're likely to lose kidney function. And importantly too, if we see that they're losing kidney function before we would expect them to based on the genetics, that might help us look for some other cause of kidney failure, kidney disease. So the indications for genetic testing, PKD we think of really as a disease of adults. So if we see children with very early onset disease, we may consider genetic testing for them. If we're thinking about a young donor who wants to donate to a family member that has PKD, we may want to do genetic testing for that patient to make sure that we're not seeing a mild form of the PKD and we're not taking a kidney from someone who may develop PKD later. If there are some atypical features that look a little bit different from PKD, then we may consider genetic testing. And for those people without a family history, we would consider genetic testing because we want to make sure we understand what the prognosis is for that patient. And in addition to these sort of established reasons for genetic testing, KDIGO also said, hey, well, maybe we should look at whether the disease is very variable within a family. So maybe one person developed kidney failure at the age of 40, but the other person didn't develop kidney failure till the age of 70. And so maybe there's a difference in that family that we should explore. Maybe there's a difference between the imaging and the progression. So we think the bigger the kidneys, the faster the progression. But if we're not seeing that, maybe we should explore genetic testing. And so I think this you'll see more and more commonly that people will start to talk about genetic testing. And then in the future, if we move towards therapies that are geared towards a specific genotype, then we may want to do genetic testing to know if you would benefit from that specific therapy. And then I told you the other new thing is that there are all these minor genes that can cause ADPKD. So the big ones are PKD1 and PKD2. And then there are a host of other genes. And the commonality here is they all affect that protein made by PKD1. So PKD1 makes a protein called polycystin 1. And all of these other genes somehow impact how much polycystin 1 is available inside the cell. And so these are different genes that cause PKD, but they're all linked by this idea that they affect cyst development through a common pathway. And it's important to know whether you have one of these minor genes because they have a slightly different prognosis. So some of these are very mild genes, mild diseases. So ALG5, ALG9 are very mild. GANAB can have both kidney and liver cysts, but usually very, very mild loss of kidney function, whereas these other ones, DNAJB11 and NEC8, can have pretty aggressive loss of kidney function. And I'm going to show you a little bit more about IFT140 because we think actually this is the third most common form of PKD, not affecting a lot of people, 1 to 2% of people, but for those people, it's really important because the disease progression is milder. And so this is typical imaging, one of my patients who has an IFT140 variant. And so what you're seeing, this is an MRI. This is the kidneys. Again, the cysts are in the bright white in this image. And you can see the kidney size is pretty normal, except for this one gigantic cyst that's sticking out here and pushing up against the liver. And then in this kidney, there are a few large cysts. But she's 70 years old. Her mother had ADPKD, but never developed kidney failure. And her estimated kidney function, so in the first talk, we heard that GFR is like a percentage, is about 50%, and 50% at the age of 70 is still really well-preserved kidney function. So she has ADPKD, but has very mild disease in terms of loss of kidney function and is really unlikely ever to develop kidney failure. So knowing about this gene, if you have this gene, it's sort of winning the genetic lottery, right? You have PKD, but you don't have something that's likely to progress to kidney failure. And they looked, a lot of centers got together and they collected their cohort of patients that have this IFT140. So they came up with a total of 75 patients. And you can see the imaging looks like what I just showed you, these cysts that sort of pop out of the kidneys. The kidneys tend not to be very large. About half the patients had high blood pressure, but really importantly, only one patient out of the 75 developed kidney failure. So very different disease and milder. And these are just showing you like what we think are the percentages of some of these rare genes. And if you have the gene, what's the likelihood that the gene is going to be expressed? So for PKD1 and PKD2, if you have a disease-causing variant, it's highly likely that you'll have the disease, whereas with some of these milder variants, the disease expression is much less. And so you may be carrying that variant gene, but may not have any disease. Okay. And then, so key points here, some of the genes which cause ADPKD are rare, but do not lead to significant loss of kidney function. But all of them may still be associated with other extrarenal, other outside the kidney issues. So liver cysts, brain aneurysms, and other complications of PKD. So we want to really keep that in mind when we're thinking about, do we need to do other screening for these patients? And then also in KDIGO, there's a whole list of genes that cause other disease that can mimic PKD. So we think of these as separate diseases, and some of them have separate screening, separate things that we do for those genes. But it's just sort of for us to know in the background that if things look a little bit different, so if the imaging looks a little bit different, if there's a lot of blood in the urine, for example, microscopic blood in the urine, or if there is another issue, then we may want to look for one of these other genes. Okay, and with that, I would be happy to take questions. Thank you very much.
Any questions? Any questions here? Oh, hold on.
I noticed that one of the leading forms of PKD that you mentioned in PKD1 is the version of where the genetic code is not encoding for the particular protein sequence. Has anyone considered using CRISPR techniques or RNA implantation in order to implant proper forms of that gene code?
Neera, did you hear that? Oh, wait, you're muted.
Sorry. Yeah, so I did hear that. And so it's an excellent question, actually. So what's really exciting about PKD, and still this is in the lab, is that people are really starting to think about these gene editing techniques as a way of treating PKD. So there's a very famous mouse called the RCRC mouse, which mimics PKD. And we're starting to see people doing gene editing in that mouse. And so there are some examples, preclinical examples of using these different techniques, using RNA inhibition, using gene editing, using gene delivery to cure PKD in mice. And so we think from that preclinical data, we'll have more information for how to treat in the next few years, how to translate that into treating patients. And so we're very, very excited about that. The other thing, so people don't always know this, but there's a researcher at Yale, Dr. Somlo, who showed a few years ago that if you have a mouse with a cystic kidney and then re-express the gene that caused those cysts to occur, so either re-express PKD1, for example, then that mouse kidney can sort of fix itself. The cysts go away and the kidney becomes normal looking again. And so that has really spurred all of these, all of the excitement about gene therapy and how you correct this disease, because it means that maybe there is some reversibility, which we just hadn't really appreciated before. So we're very, excited for these future therapies.
Okay, Neera, we have some online questions. The first one is it possible for someone to inherit a milder version? If you are transplanted, can you get genetic testing? How would you get the genetic testing? I am a patient at UMMC, that's here. So
Okay.
we
All
know
right.
how to get that, but go ahead.
Sure. So yes, absolutely, it's possible to inherit the milder version. All of these genes are autosomal dominant, and so we think that the same way that 1 out of 2 chance of inheriting any autosomal dominant gene, it can be mild or it can be severe, but you can inherit it. Even after transplant, we can test for the gene that you have. And the reason we can do that is we think that the genetic variant is in all the cells in the body. It's not just in the kidney. So we can get some blood, or we can get a sample, a genetic sample, and we can test to see what variant you have. And Dr. Watnick certainly can tell you how to do that genetic testing.
Okay, next question. I am a 56-year-old woman with a PKD1 truncating mutation and quote stage B, estimated GFR 72. My biological father needed a transplant in his 40s. My 23-year-old son also has the PKD1 truncating mutation, currently with normal kidney function. What is the likelihood that they will experience end stage later like me?
Yeah, so this is that question of variability within families, right? So this is a really good example where her dad needed a transplant in his 40s, but she's doing well at 56 with really still pretty well preserved kidney function. So there are a couple of points to make here. One is we know women progress slightly more slowly than men, so there's some protection there. The other is we look at imaging. So we know that these genes cause disease, but looking at the images and knowing what the total kidney volume is, really also helps us predict progression. So we look at both of those things together. So I'm guessing that at the patient asking this question, Jess, who's asking this question, probably has smaller kidneys than her father had at the same age. And for thinking about her son's prognosis, it would really be helpful to know that Mayo imaging classification to help guide further discussion around prognosis.
Okay, Neera, here's a good question. If you have an IFT140 mutation, is there a chance that you will have no kidney cysts?
So that is a great question. So that's the one where we think of just a few cysts. So let's see if I have, so the answer to that is yes. So looking at the data, this is data, so MCBB stands for Mayo Clinic Biobank. And so this is one with reduced penetrance, meaning that people with the gene, some of them may not have any cysts at all. So that's a great question, and the answer is yes.
Okay. Here's another online question. This is interesting. My dad and his identical twin brother both had PKD1 non-truncating mutations, but dad had severe liver cysts and his twin brother had almost no liver cysts. Is this most likely due to another genetic difference, or could it be environmental, including dietary? I'm 4th generation and a researcher, so I'm curious. So
Okay.
I guess these are identical twins with different liver cyst burden.
So I don't think, and Terry is also, please, if you have an understanding, I would say we don't really know enough about liver cysts, even within the same genotype, right? So PKD1 truncating, non-truncating. Some people may have a lot of liver cysts. Some people may have a few. Here, there are 2 identical men, right, who have a different liver cyst burden. So I'm not sure I know the answer to that. there could be some environmental and dietary differences, as you point out, like because they're twins, we would assume that those are the differences. I don't know, Terry, if you have other thoughts about that.
Yeah, I mean, it's really interesting, and because they're identical twins, or I'm assuming that's accurate, then it must be something else that's happened since birth. So I think environmental is a good bet, medications, things like that. But yeah, it's interesting. We only have time for one more question, so let me do this one. Does medication such as blood pressure medication affect cyst growth or have impacts on kidney function decline?
So the first rule for treating PKD is managing the blood pressure and managing the blood pressure appropriately. We think that for people, so from the HALT PKD study, which is the big major study that people did for looking at blood pressure, what we saw was that with more tight blood pressure control, there was a benefit in terms of cyst growth and a benefit in terms of reduced total kidney volume over time. In that study, they didn't see a benefit in kidney function with the tighter blood pressure control, but we think from looking at other kidney diseases that treating blood pressure is important, that that high blood pressure can have an independent bad effect on kidney function. And so we recommend blood pressure control for everybody. And then for those people at highest risk, a slightly lower blood pressure threshold to help reduce the burden of cyst growth.
Okay, thank you, Neera. Thank you very much. It was excellent. Thank
Thank
you to
you.
both our presenters, Val, Neera.
This concludes part 1 of the recording of the 2025 PKD Education Forum. Please continue to watch the second part to hear the rest of the presentations.